All right, we'll start recording now. Hello, welcome to everyone who's joined us today. We only got limited numbers to start off with here, but hopefully people will join us throughout the session. And if not, there is a recording of this which will be made available online. Welcome to today's session. We're very lucky to have Anne Morris with us today, who presented the last session on understanding diabetes. The session today will be around diabetes and lifestyle, and we'll take you through a little bit more of the purpose of the session later. I'll start off just with the acknowledgement. So Motivation Australia would like to acknowledge the traditional owners and custodians of the lands from which you are all respectively joining us. For us based in Motivation Australia office, this is the Kaurna people. We respect their spiritual relationship with the country that has developed over thousands of years and the cultural heritage and beliefs that remain important to Kaurna people today. It might be good if everyone just wants to write in the chat, say hello in the chat and write where you're joining us from today. It'd be fantastic to hear from you all. And we'll give everyone else an opportunity to do that as they join as well. So I'd like to essentially hand over to Anne, who a lot of you will have met last week. But Anne, you might want to introduce yourself again.
Thanks, Daniel. So hello, everyone. It's lovely to be with you all again today, and thank you to Motivation Australia for asking me to do this session again, do another session with you all. I've had a lot of experience with diabetes. I also lived with someone who had diabetes, and so I can see it from both sides of the experience. I've been a diabetes educator since 1976. 46 years, it's a bit scary. And I have been very lucky to be acknowledged for the work that I do by the Juvenile Diabetes Research Foundation, as per the slide. And in 2016, I was incredibly privileged to win Diabetes Educator of the Year, Australian Diabetes Educator of the Year, which is an amazing thrill, really. So that's a little bit about me. So hopefully today we're going to talk a little bit about lifestyle and the factors that influence diabetes. And we're talking about the causes of diabetes, but we're also going to think a bit laterally about some of the contributing factors that type 2 diabetes presents us with. And as per the session we did in June, I guess it's important for us to also understand that, we talk about lifestyle a lot with regard to diabetes. And as you'll see in my first slide, you'll also realise that there are other contributing factors to what we have to manage with diabetes, and that diabetes isn't as straightforward as type 2 all the time to us who are working in the clinical setting. Next slide, please, Daniel. So the causes of type 2 diabetes are not just purely lifestyle factors, and I think we have to understand this. There are a lot of genetic influences, but there are also other contributing factors. So we also know that developing a major illness can lead to the onset of type 2 diabetes and the physical stress from that. We also know that emotional stress can also be a trigger to the onset of diabetes. We also know that people who get put onto steroids can develop a form of diabetes known as steroid-induced diabetes. And we also know from the UK PDS that the history of high blood pressure is a high risk factor for the development and the likelihood of type 2 diabetes. And the other thing that is a high risk factor for type 2, which we talked about last time, and I haven't repeated the slides because I just assumed we'd already talked about them. But of course, women who develop diabetes in pregnancy have a 50% chance of developing type 2 diabetes within 5 to 7 years after the delivery of the baby. And that's an incredibly important risk factor. In this country, as I would have said last month, in this country, all women get checked for gestational diabetes when they reach about 26 weeks gestation. And that's because there are comorbidities associated with the pregnancy and the risk to the fetus, but also because we also want to put them on a database and keep an eye on those women, and we monitor those women actively if the diagnosis is made. So it is an important part of the data collection that we do here. And I don't know whether you do it in your countries, but it's certainly something that you should think about doing in terms of your own individual services. What we do in this country is we follow those women up with a glucose tolerance test 6 weeks after delivery. to ensure that the glucose tolerances return to normal and they stay on our databases for 5 years or so to see whether or not they've re-triggered an activation of their reference. So that's an important thing for you all to think about. One other thing I'll put on this slide, and I can't remember whether I talked about it the last time, is that we do know that a lot of people who develop type 2 diabetes already have an insulin secretion defect at diagnosis. And that really means that they are likely to require medication intervention sooner than other people may. And we certainly know that there are these factors that I've talked about on top of lifestyle contributing factors. We also know that when we can modify lifestyle, that we do get extra benefit over and above any other medication or interventions that we put in place. So lifestyle does become a very important part of management. It's just not the only part. And I think we have to see it as a part, not a whole. For some people, it certainly is a whole, but we also have to see that other factors will be at play. Next slide, Daniel. So the lifestyle changes that we know will help, first of all, include healthy eating. This is not about not having the occasional treat. In fact, we do encourage people who develop diabetes to actually give themselves an occasional treat. It's really more about what that treat looks like and how often it's honestly consumed. So we obviously encourage plenty of fresh fruit and vegetables, whole grain breads and cereals, restrict the intake of a high glycemic index food such as ordinary soft drink, ordinary jellies, lollies and sweets which contain added sugar in large quantities. These foods are certainly not recommended because they do raise the glucose very quickly, and unless they're being used to treat a low blood glucose, they don't hold any place in the regular sort of intake of people with diabetes, just because we have to then intervene to actually manage those scenarios. And if you're dealing on top of all that, if you're dealing with wound healing issues, it just impairs that progress even further. So we restrict the intake of those foods because of that. And we obviously want to increase the intake of low glycemic index foods, which are generally seen as the more complex carbohydrate foods, which are more slowly absorbed and don't have a high impact on glucose or sugar. Next slide, please. Right. So the other thing that we also know will be regular exercise. Now, I guess, you know, there are lots of issues in regard to this particular part of lifestyle change. And if people that you're seeing have got wounds to heal, if they've got foot deformity, if they've got amputation, then they're all going to make a huge impact on the person's capacity to have regular exercise. One of the things that we talk about with people with diabetes in this country certainly is the fact that if you're going to change behaviour to develop more exercise, you have to start slowly so that the person can adjust, the person's body can adjust to the change. If you start people trying to do too much too quickly, they either have a sense of failure or they actually can't maintain it because it's too hard. And then there are other risk factors associated with that. So we always get people to start gently, make sure they've got a doctor's okay to do this, but start gently and to gradually increase the amount of exercise that they do. So for instance, what we might say to somebody is go out of your home and walk 10 minutes up the street, then walk 10 minutes back, or walk 15 minutes up the street and walk 15 minutes back, so that you then develop a situation where you're walking for 15 minutes, but you've got to come back home. So you've got to walk the other 15 minutes. And that way people are getting 30 minutes of exercise that way when they do it in a continuous block. And that's also the other important element to this. So it's really more about trying to get people to see that small steps actually are achievable with regard to exercise. And it's not for everyone that people will be able to go to a gym or go and do, you know, a jog or, you know, to do some sort of really strenuous exercise. It's all about starting in a way that you can maintain And we often give people a guide that says, if you can walk and talk, it's right for your level of tolerance. So if somebody wants to go for a walk and they go with somebody, which is usually a good idea, we usually say to them, if you can walk and have a conversation with that person, then it's the right pace for your level of fitness. And that's really important. Next slide. So I think the other thing to talk about here, and this is a much longer slide to talk to, is that, you know, if people are struggling, they need to have regular review. So being in touch with their nurse or their doctor to continue to maintain motivation and to recognise that small steps are being achieved is really important in trying to maintain their energy and their exercise and their sort of strategies, I suppose, their inertia, their self-care inertia. So it's really about saying, okay, let's just talk about this. What else can we do to help you achieve the small goals you want to achieve, and help them along the way so that they feel supported and they don't feel as though they're doing it on their own. But in fact, you know, you can also see that if they are also making progress and there is some weight loss being achieved, or there is some improvement in exercise tolerance, that maybe, and their diabetes isn't improving, that maybe it's time to look at other things, and adding in oral medication is certainly a strategy that needs to be assisted. And I talk about that at the bottom of that slide, where we'll talk a little bit more about that medication. We did talk about this the last time, but we'll talk a bit more about that and its role in behaviour change. Obviously, people need to stop smoking to minimise their cardiovascular risk factors. If there is stress, emotional or physical stress, or mechanical stress, obviously these things need to be taken into consideration that then allow the person to become more motivated. We do measure for what we call diabetes distress in this country. I don't know whether any of you know about it, but diabetes distress is a burden of disease measure, which measures how that person sees their diabetes. And when there's a lot of burden, it does impact on people's capacity to look after themselves. And I can send it through to Daniel if you'd like to know more about it. It's a universal tool. It can be incredibly useful to determine whether or not a person is overwhelmed by their diabetes or if they're managing okay. If they're overwhelmed by their diabetes, then that is in itself a barrier to people being able to actively manage their condition. And when if we talk about diabetes education, we'll talk a lot more about that and using that in the way we can assess people's capacity to self-care. Alcohol intake is high in calories, apart from the other things that it contributes to in their well-being. They're high in calories, it's empty calories. And the body will process that before it processes anything else. But people who have a high alcohol intake also have a higher calorie intake, and this leads to weight gain. So we really are trying to limit alcohol intake to minimise weight gain from those calories that are, as I said, they're basically seen as empty calories. We shouldn't exclude medication here. And we did talk briefly about semaglutide and dulaglutide last time. Semaglutide is known as Ozempic, and dulaglutide is known as Trulicity. That's right. And so they are very useful medications which our public benefits, pharmaceutical benefits scheme subsidises. Apart from the physiological benefit here, which I'll put on the screen, it mimics the gut enzyme, which improves insulin action and sensitivity because it does actually suppress glucagon, and it reduces the production of new glucose by the liver, new sugar by the liver. And those things are active in type 2 diabetes. Those physiological responses occur as part of the metabolic syndrome, okay, which causes insulin resistance. Well, it's one of the things that causes insulin resistance. So does high fat stools causes the same thing. But this medication is incredibly useful in helping people to actually modify their behaviours in regard to lifestyle. So, for instance, particularly in regard to food intake, and it's directed at that, this medication will do, on top of the things that I'll put on the screen, this medication improves satiety. So what that means is that people feel full much sooner on a meal than they would normally do. And what that leads to then is that because they're having a much smaller meal, they generally lose weight. And because they're getting much more efficient use of their insulin that they're secreting themselves, their blood glucose levels respond very well to these strategies. So it's a combination of physiological as well as behavioural. And because if the person eats through that satiety, in other words, if they break through that feeling of fullness, or if they eat very high fat meals, so if they eat junk food, takeaway food that's not ideal, they will feel incredible nausea because it does inhibit gastric emptying to the point where if they overdo it, they will feel nausea and they will vomit. So it actually facilitates modification of behaviour because those symptoms are then the outcome of breaking through that feeling of fullness and breaking through that meal satisfaction, and as well as choosing a less optimal choice, which is, as I said, if they're high in fat, people will in fact get incredibly unwell with it. And so I don't know whether or not there is an opportunity for any of you to approach the government to at least look at these medications, but because they are weekly, people living in remote communities, which of course we have in this country as well as you, people living in remote communities are much more likely to be able to manage storage and or access to these medications because they're not every day and they're not multiple times a day. So they work incredibly well in our isolated communities because of their weekly their weekly dosing. And I would certainly encourage any representation to your health department to include at least one of these medications in the list of available options that you have, because they are quite incredible in the way they modify behaviour in their own right. And because people achieve results pretty quickly, diabetes responds very well. And because it's only a weekly injection, which some people may resist because it's an injection, it's not a tablet, nevertheless, it's something that they could come to a clinic to actually receive. They don't actually have to give it themselves, although it's very easy to do. Both devices are incredibly straightforward. So it's something that you should really give some thought to. And so, managing lifestyle issues is not just about exercise and diet. There are other strategies that need to be considered, and so that it becomes a holistic approach to managing that person. And there are all sorts of things that impact on their capacity to actually undertake lifestyle modification, which have to be looked at as per the individual needs and scenarios. Daniel, yeah. So discussion questions, I guess, is really about, looking at the sorts of things that we might have to talk about. Here we are, we talked a little bit about this last time. So when we look at this again, there are all sorts of strategies that you need to have a conversation with this person about, aren't there? So after today's very, very brief talk, and can I just say, I'm sorry it's so really short today, because in this country, we've just allowed access to people with type 1 diabetes to access continuous glucose monitoring systems where they can monitor their glucose continuously. And it's subsidised from last Friday. So my time available to you today is really short. I apologise again. But here is a scenario that we looked at last time. And so your considerations, if you had access to some of the things we talked about, would be, okay, so what might we want to look at for this person?
So yeah, just to add, thank you, Anne. And yeah, I would be interested not only just for this discussion question about, what are the lifestyle factors that people would consider, but then also to hear more about some of the diabetes education around food intake and also exercise that are available in each country, because that's, something that I know the Australian government is always trying to do. We've had the 2 and 5, so eat 2 fruit, 5 vegetable a day for a very long time. I'm not sure if that's current anymore though, Anne. I'm not sure if you know.
Oh, it is. It is still current.
Oh, it is still current, yeah. But yeah, I'd be interested to hear if there's any sort of campaigns or strategies around nutrition or exercise in Papua New Guinea or Solomon Islands. I think we have online as well.
I mean, I think probably something to bear in mind is that while we've presented a very clean looking sort of, it's not as simple as the slides suggest it is. And those of you who are working in the clinical setting already know this. These are not easy scenarios to actually get people to feel they want to be empowered to do, because there's a lot of physical barriers that people find difficult to overcome. And it's about trying to motivate people to do it and to see that there are benefits that undertaking restriction or healthy eating choices and regular exercise means that they're less likely to require medication intervention. And there are sometimes motivating factors to say, right, look, let's make sure that we can get you as well as possible to heal this up. There are all sorts of motivating conversations to have here. We can do a talk on, what we can be quite specific, but, it'd be nice to, as Daniel said, it'd be nice to hear from all of you about what public health strategies are at play in your countries. Because even though we presented a lovely, clean scenario of these are the optimal things to do, we all know how hard it is to actually get people to engage in those things. And it's not just your countries, it's just about every country. They're not unique to any of your countries. We have a huge problem here with people having more and more sedentary occupation. There's less of a need to, work to get our food as we used to do many years ago. We are much more sedentary in our lifestyle in this country. We have been for a long time. And even though there are lots of positive research and there's evidence to show the benefits of standing up at elevated desks and all the rest of it instead of sitting, we also know that it's incredibly difficult to get people to undertake lifestyle change because they have to move outside their routine. They often have to go out when they don't want to. They might have been working hard all day. They get home and the last thing they want to do is to go for a walk. It's incredibly hard to sometimes make people create those choices within what is already a busy lifestyle. And it doesn't matter what that lifestyle looks like to that person, it's relevant and it's relative to them. So we mightn't think it's a busy lifestyle, but if they do, they've got to try and manage to fit something else into it. And that's not always an easy thing to do. So it's about finding ways to identify these things to people, just like I talked about a little while ago about walking 15 minutes away from your house and back again. There's a 30-minute walk. But if you do it in 15-minute chunks, it doesn't seem so bad. And so it's really about presenting that information in a way that makes it seem accessible and that makes the person say, oh, yeah, I could go for a 15-minute walk. That's no help. Or 10-minute walk or a 5-minute walk, depending on what their mobility is like. Remember, you've got to start at a point where they can actually see that it's achievable. And once they start to see that it's achievable and they start to get support in making the changes, then, it does start to, the small steps conversation is really important to reinforce. I think when we're talking about, for instance, food choices, and we're saying to people, look, use what's in your pantry or your fridge or whatever, and use those things that are less ideal first, but replace it with things that are these things to choose from. And we have a very good resource, which is a supermarket shopping guide, and people can actually get to see what the preferred choices are. So they actually do benefit from the resource, because they can say, oh yes, well, I'm using that and I'm using that, but I shouldn't use that, and if I do use that, I need to replace it with that as a better food choice. And so developing those sort of resources for your people with diabetes, for patients in your care, can be incredibly useful, because then you're empowering them to make the choices, but you're also guiding them to the preferred choices by giving them, this is a list option, this is an optional list, this is the optimal list, these foods are preferred, these foods are less preferred, and giving them, just making them understand what those differences are. And so it's not just a straightforward, just do this. And we all know that. We all know because we're working at the coalface.
Perhaps if there's no discussion around this question in particular, and we can move on to just general questions and answers. What do you think?
Yeah, I've only got a few more minutes, Daniel.
Okay, yeah. So just another opportunity for anyone to ask and general questions about diabetes in general, first of all, but also lifestyle factors that we've spoken about today, or general diabetes management. So any questions are okay.
I think too, while you're thinking about those questions, I think too, remembering that I said that 50% of people with type 2 diabetes who develop type 2 diabetes have an insulin secretion defect. It's not as straightforward as just about lifestyle. And so I know there's a lot of people say that you can actually put diabetes into remission. And for some people, that's actually very true. They do achieve remission, but it's called a chronic condition for a reason. There is no cure, and we have to put it in the right context for what we need to do and how we need to set that person's mindset up. If we tell that person there is a cure, then we're misleading them. And if we say that there is an opportunity to put your diabetes into remission, then that's a different mindset. It's the same mindset as calling diabetes a disease or a condition. If you could tell someone they've got a disease, it's a sickness model. If you say someone's got a condition, then it's more of a wellness model. And so it's the same sort of language choices that we need to be careful about when we're talking to people, to make sure their mindset doesn't go off in the wrong tangent.
Feel free to write questions in the chat box as well if you don't have audio or just don't feel comfortable talking. We got Alfred. Thank you, Alfred. Has done exactly that. Alfred said, as a health practitioner, it can be easy to explain and persuade a patient to follow a healthy lifestyle if we practice a healthy lifestyle. So you speak from your experience more than just making reference from a book or a presentation. Good point, Alfred.
I agree, Alfred, very much. Can you see me? Can you see my dog, everyone? Can they see my dog?
I can see your dog. I'm not sure if everyone else hopefully can.
Yeah. Can you see my dog?
Peter can see it. Oh, we have Department of Health too. Which Department of Health is that? Sorry, if you could maybe just write in the chat box. Department of Health agrees with Alfred.
Yeah, I agree with Alfred too. It's a very important point.
Okay. It's Lena and Elsie at Knobs Port Moresby. Hi, Lena and Elsie. Thanks for joining us. P&G, Department of Health. I am wary of your time, and so feel free, everyone, to keep writing questions in the chat box, or if not, I'll send out a survey link after this session, and you can write any questions or any feedback for the session in the survey, and I'll forward them on to Anne to answer.
Like I said, I'm sorry it's so tight today, everyone. I've just got all this stuff happening around me, so I'm really, really sorry. It was very, very quick.
Thank you for your time, Anne. And like Anne mentioned, there will be there is scope for more sessions on diabetes. Obviously, it's a huge topic, diabetes education. So we're planning probably another session on exercise considerations for people with diabetes. And yeah, happy to have any other suggestions around diabetes educational management topics.
And there are heaps of them. It's more about what meets your need. Hopefully we'll be fine next time we meet.
Yeah. So thank you, everyone. Thank you, Anne, for your time once again. And thank you to all that have joined us. I did have apologies from the Ministry of Health and Medical Services in Solomon Islands today. So they couldn't join today, unfortunately. So that's quite a number of personnel unable to join, but the recording will be available online. So please feel free to share with all your colleagues. And we look forward to seeing you at the next session, which will be once again on Tuesday, the first Tuesday of August. And I'll send
the 2nd of August.
It's the 2nd. Thanks, Anne. Got my back there. 2nd of August, and I'll send out more details by email.
Okay. Good luck, everyone. Thank you. And again, my apologies for being so quick today.
Thanks, everyone. Thanks for joining us.
Thank you. Thanks, everyone. Bye.
Yeah, bye.
Bye. Bye.